Okay, so this next section is major endocrine disorders, and I'm not going to cover every endocrine disorder because we've actually talked about a lot of them throughout the semester. Like, for instance, I'm not going to talk about the renin-angiotensin-aldosterone system again because we talked about that back when we talked about electrolytes, when we talked about the kidney. I'm not going to talk about erythropoietin anemia again in the process because we talked about it in the kidney extensively, and then we talked it again in the blood and cardiovascular again. So a lot of these disorders that are technically endocrine disorders we've covered in the past. I'm just going to cover the ones that we really didn't cover, but you need to know when you move beyond this class. So the pineal gland I talked about briefly when we talked about the nervous system, but you have to remember that I'm pointing this out because not every cycle is negative feedback or positive feedback. You can have some of these cycles that are driven by things that are other than just a negative feedback loop. The pineal gland is driven primarily by a diurnal cycle, and that's also driven by seasonal cycles, but diurnal is referring to day and night. So melatonin, if you remember, is the chemical that comes out to play when it starts getting dark out. So the darkness comes along, excuse me, and you release more and more melatonin. You take, it makes you sleepy, you take that long nap. During your sleep, you're going to release things like cortisol. You're going to release things like growth hormone. So other hormones in conjunction with this melatonin, but melatonin is kind of the sleep regulator as far as hormones go. So some of the characteristics we haven't talked about extensively about melatonin were it's an antioxidant. It actually protects the DNA. So when you're sleeping things off after you've had an injury or damage or you had a really long exertional day, the melatonin is there to help protect that DNA while you're clearing all that stuff and repairing all that machinery. It's there for learning and memory. LTP is called long-term potentiation, and this is the process of basically keeping your memories good and solid. So consolidation is the process of taking it from your regular thoughts into your long-term memory, but long-term potentiation is kind of like reactivating it and making sure it's a really good solid connection. So melatonin helps us with that. So when they talk about how melatonin and sleep and memory work together, that's why. Melatonin is kind of the connection hormone. It increases your immunity. Remember when you're really sick, what do you want to do? You just want to sleep a lot. Melatonin comes out, increases the activity of your white blood cells, and causes you to repair faster. It's there for metabolism. It helps you regulate metabolism. It actually makes you hungry because you're burning calories when you sleep under the influence of melatonin, but it also gives you those cravings. So have you ever defied sleep and not gone to sleep, but it's really late at night and you start getting all those cravings and things? Melatonin is one of those chemicals that help boost that. And then it's also used as a contraceptive. And this is kind of like a drawn-out, detailed explanation that I'm not going to get into. But think about the seasons. When it becomes wintertime, what happens more? More darkness or more light? It's more darkness. You get more melatonin. Well, in traditional winters, it's extremely cold. It's not the best environment to have pups if you're an outdoor animal or kittens or whatever. So they find that melatonin actually, when it's a higher level, acts as a contraceptive. It turns down reproductive cycles, so you're less likely to get pregnant in those long winter months. Doesn't mean it can't happen, it just means it reduces your ability to, or especially if you're an outdoor animal. So some of the problems that come along with melatonin are, of course, sleep disorders. People that are doing this night shifts and they're trying to stay awake when their melatonin levels are actually high because of the darkness, they're really messing up their sleep cycles. And we talked about sleep disorders back in the nervous system. Seasonal affective disorder, because of melatonin levels being disrupted. Autism, Alzheimer's, there are some other diseases like these that revolve around memory and thinking and concentration that they find are actually kind of might have risk factors that involve melatonin levels being out of whack. There are also some fruits like cherries, bananas, grapes, rice, and wine that you could drink that have high levels of melatonin too, which is why some people, when they've had a glass of wine in the evening, they just kind of feel tired and helps relax them. It's helping boost their melatonin levels. So the next organ you have to remember is the hypothalamus, and we've talked about this so much this semester, and in prior semesters in anatomy and physiology you've heard about it, but it's the homeostatic center, remember? Freezing, feeding, fighting, fornicating. Well, the hypothalamus also regulates everything that's going on in the pituitary gland. So if you look at the connection, here you have the hypothalamus up here, it releases a bunch of hormones that are pituitary releasing or pituitary inhibiting hormones. Those hormones, if they're going to the front pituitary, the anterior pituitary, they get dropped in the bloodstream, go down through the stalk, and then they stimulate those cells that hold the hormones in the anterior pituitary. So these hormones just sit there. If your hypothalamus doesn't say what to do, they don't get released. The same thing with their inhibitory hormones. You can release inhibitory hormones like growth hormone, inhibiting hormone, that gets dumped in here, comes down here and stops growth hormone from being released. The other side of the pituitary, the posterior pituitary, has a neural connection to the hypothalamus. So this is kind of tricky. The hypothalamus makes the hormones up here, which technically right now they're called neurotransmitters because they're made in a neuron. They travel all the way down the axon, and then they get stored in the axon terminal. They sit there. When the hypothalamus wants to release it, it sends an electrical signal down the axon, stimulates the anterior or the terminal in the posterior pituitary, and it dumps those hormones into the bloodstream. So the posterior pituitary is actually just neural tissue. It's an extension of the brain, and it's there to store hormones. It doesn't make anything, it just stores them. When it wants to be released, hypothalamus sends a signal down and releases it. Right? That's the hypothalamus. The hypothalamus has a lot of other functions besides endocrine, though. You have to keep that in mind. So the next one, the pituitary gland, they call the master endocrine gland because it's exclusively endocrine. Its whole purpose is endocrine. That's it. What's interesting about that name, master endocrine gland, is that in reality, it can't make a move without the hypothalamus. So to me, the hypothalamus is kind of the master in this situation. But they call the pituitary collectively the master endocrine gland. So all the hormones that are in here are made out of proteins or peptides. What do you know about them? They all love what? Fat or water? They love water. Do they work quickly? Yes, they do. So they go, they bind the outside of a cell, they turn on that cell, and they activate some kind of second messenger in it. So when you see these things, you should by now, after physiology and now here, you should know these are important concepts. If you know the properties of a peptide protein hormone, you can kind of apply it across the board to how they work and how they get cleared. Right? So the adeno-hypophysis versus the neuro. Adeno is telling you that this is coming from epithelial tissue. Neuro is telling you it's coming from neural tissue. When these two things grow together, the adeno grows up from the roof of the mouth, pouch of Rathke, or Rathke's pouch, and then neuro grows down from the brain. They just merge together here. That's why the posterior is full of these neurons and the anterior is full of, hormones. So endocrine. Endocrine, remember, is modified epithelial tissue. And then the anterior pituitary we'll go through first. And I always remember flat pig. So the F-L-A-T and then P-G for flat pig reminds me that there are the 6 important hormones that come from the anterior pituitary. They're all stored there, they're just waiting. And they're stored in these special types of cells. Like a corticotroph stores up this thing called adrenocorticotrophic hormone. When it receives CRH from the hypothalamus, so the hypothalamus sends CRH down, stimulates the corticotroph releases ACTH into the blood. Well, ACTH has to go to the adrenal cortex, hence adrenocorticotropic hormone. So it goes to the adrenal cortex and stimulates the release of glucocorticoids like cortisol. And then that cortisol's final effect is to help you deal with stress. Raise your blood sugar, raise your blood fat, raise your blood amino acids. It's there to help raise energy sources in your blood so your brain can think quickly. It raises your blood pressure to try and gush the blood up into your head. So if you remember those different things, and you might want to go back to your physiology book or even go to the review section of the pathophysiology book and go back through that and just make sure you know what the main purpose of each of the hormones are. Because if you know the main purpose, when they break, you know exactly the symptoms you can predict. So somebody that has this pathway broken, went backwards, sorry. Somebody that has this pathway broken, what are they not going to be able to deal well with? Stress, right? What's going to happen to their blood sugar levels? Well, if cortisol raises your blood sugar, their blood sugars might stay lower. If cortisol raises your blood amino acids, the amino acids may stay lower in their blood. If cortisol raises the lipids in your blood, the blood lipids may stay lower. So what would be a problem if you had too much of that, right? So if you have too much cortisol in your system, it's going to make your blood sugar stay high. It's going to make your blood lipids stay high. Remember when we talked about triglycerides, free fatty acids in the blood, what they do? They cause things like atherosclerotic plaques. So it's going to make these plaques start accumulating. It's going to bring your amino acids up really high, which will make things called ketone bodies that we'll talk about in the next section. So having too much cortisol basically kind of mimics diabetes. It spikes your blood sugars, makes these ketone acids that are like a diabetic has. It makes atherosclerosis, which can cause circulatory problems, just like diabetes does. It looks a lot like diabetes. It causes hypertension. So you can go through and look at each of these. So FSH, LH, these are the gonadotropins. You can look at the pathway. Their final destination is the gonads. They're going to help increase things like sperm, They're going to help increase the development of eggs. They're going to make estrogens. They're going to make testosterones. That's their goal. They're gonadotropins. They nurture the gonads and they produce these. So if you had too much of this, you might expect overproduction of something like testosterone, lots of sperm count. If you have underproduction, you may see low levels of estrogen, low levels of testosterone, low sperm count. You know how to figure out hypo and hyper once you remember these different types of hormones. And then TSH, called thyroid-stimulating hormone, comes from the anterior pituitary and goes to the thyroid and stimulates it to release T3 and T4. Well, T3 and T4 are there to increase your metabolic rate. I lost it. There it is. There's the pathway. So increase your metabolic rate, your basal metabolic rate. It brings your temperature up. It helps you release some nutrients into the blood so you have quick energy. It helps turn epinephrine on. It helps act with estrogen. It helps act with growth hormone. So TSH is a really important hormone for releasing T3 and T4, which definitely affect your metabolism. So if it controls metabolism, if you have a high amount of this stuff, what would you predict it would happen? Well, lots of metabolism means what's your weight going to be like? You're going to be burning lots of calories. You'll probably be hungry a lot. What's your body temperature going to be like? Really warm. So hypersecretion of this hormone, you'd expect those symptoms as a final response. Well, what if you had hyposecretion of these hormones, TSH and T3 and T4? You'd expect lower metabolism, not so hungry, not burning calories, maybe a colder body temperature. Of course, you're going to gain weight. So those are the characteristics. And then prolactin, and we're actually going to talk about two chemicals, prolactin and oxytocin. So prolactin and oxytocin kind of work together, and when they work together, they help produce milk and release milk, so letting the milk go. And then growth hormone, of course, is going to help you grow. So if you were to look at a situation like, let's say, you had a tumor growing right here. So the pituitary gland actually sits at the base of the skull inside of bone. It's surrounded by bone. If there was a tumor here, it would compress this. What would you expect? Would you expect all these to start hypersecreting or hyposecreting? Well, they'd hyposecrete. If you pinch this flow off, they're not going to make their hormones. So you would hyposecrete all of these things. What kind of symptoms do you think you'd predict? And I'm actually going to let you hang on to that and ask you a question. So what kind of symptoms do you think you predict by lower FSH, LH, ACTH, TSH, prolactin, and growth hormone? Okay, and then hyperpituitarism. Typically, hyperpituitarism is when one of these cells mutates. So if this one cell mutates, you make lots of ACTH. That sends a lot of signal down to the adrenal glands telling them to make lots of this cortisol. Man, you're always going to have higher blood sugars. You're going to have high blood lipids. It's going to be bad news for you. There's actually a disease that has its name called Cushing's that's talking about this pathway. So we're going to try and go through, and hopefully you're remembering these different chemicals and what they do with these hormones. If not, go back through your book and refresh. Because when we talk about the diseases, you can see we're going to go back to these pathways. Okay. So hyperpituitarism, what kind of things would you expect? And I actually kind of went through this without thinking about it, but FSH and LH, you see hypergonadism. Like in males, high testosterone, right? So they're going to be maybe more aggressive. They'll have bigger muscles, maybe a lot of acne, maybe very hairy eyes. Right? So that would be hypergonadism. ACTH, I just discussed Cushing's syndrome. TSH, that would cause hyperthyroidism, increased metabolic rate, increased burning calories, increased body temperature, all those things. With prolactin, this is interesting because prolactin, I know it starts promoting milk production, but prolactin, while a woman's pregnant and she's releasing lots of prolactin to breastfeed, what does she not want to do with her uterus during this time? She doesn't want to make another baby. So prolactin will actually shut off the feedback loop with FSH. Prolactin shuts off FSH, shuts off LH, which shuts off the high levels of estrogen that she would normally be making. It shuts off her ability to develop this next egg. So here's an interesting thing. If she had a prolactinoma, which is a tumor that is oversecreting prolactin, what would happen to her reproductive cycles? Would she continue having them? Would they be more frequent or would they be less frequent? Well, if she had a prolactinoma, it would cause things like amenorrhea, which means without menstruation, which means that her menstrual cycle stops. It stops during that time that she has too much prolactin. It may cause galactorrhea, which means she's making lots of milk now. So galactorrhea is actually a spontaneous flow of milk from the breast, and it's not even associated with childbirth or nursing. It can just happen. So sometimes you get these things called adenomas that affect specific cells in the pituitary, and you get an overproduction of whatever that chemical is. And then gigantism, if you have hyperpituitarism, you'd see more growth hormone, which would cause gigantism in children. So as a child, as long as your epiphyseal plates are not sealed shut, their bones get longer and longer and longer. And this guy is Robert Wadlow. He's the tallest man in history. He's actually from Alton, Illinois. And he was 8 foot 11 inches, tallest man in the world in history. And he's passed since then. But that's what happens when you have too much growth hormone in childhood. When you have too much growth hormone in adulthood, your epiphyseal plates have sealed on your bones so they don't get taller. Can they still grow? Yes, they can grow wider. So they get more broad. And you see it more in the flat bones or the shorter bones, like in the fingers. They get very broad. You can see flatter bones like in the skull or the jaw. You see how this woman's jaw, she looks like normal. I think she was like 16 here. I have this in another slide with it. I have ages on there, but it's like 16, and then it showed her maybe in her 30s. Maybe this is in her late 30s, and then here's in her 60s. But you can see the progression. She looks very normal in the face here, but her jaw just keeps growing, and her forehead keeps growing. And, of course, if it's growing, it can compress the brain. It can cause eating problems, movement of the jaw, dislocating the jaw easily, etc. And then this guy here, also acromegaly. So you can see his face and his jaw just keeps growing throughout adulthood. That's acromegaly. If those bones, those flat bones, keep growing too much, think about the bones in the skull that have little structures in them. Like when you talk about the auditory canal, the incus dimalis and the stapes. If that bone keeps growing, it could actually disturb those, so it might cause hearing problems. Think about blood supply going up into the brain. So like the vertebrobasilar system that takes blood up to the back part of the brain. If that's compressed or pinched off, then they could actually decrease blood flow to the occipital lobe and cause vision problems. It could cause problems with the brain stem, so maybe vomiting, nausea, all of those different things. So kind of think of what are the consequences of these changes. Right, so now hypopituitarism. So what are some of the typical causes of hypopituitarism? Think about the structures here, and I already mentioned a little bit. Maybe you have a tumor that's compressing this blood vessel. Maybe you have a tumor that's compressing those neurons. So here are the typical ones, and I like that they all start with I, which makes it a little bit easier to remember. So you can have invasion. You can actually have tumors that grow in or smash the blood flow. You can have an aneurysm that's swelling. So one of these blood vessels could be swollen, too much pressure here, and it swells out and it compresses it, which is actually like Sheehan syndrome. Sheehan syndrome, it's, I think I have it on here. Yeah, there it is. Sheehan syndrome is actually what's happening is that the blood vessels are blocked going in there, and it typically happens after childbirth, so postpartum. As she's squeezing, it causes rupture and damage to those blood vessels. They get blocked, and then suddenly her pituitary doesn't work, and it causes all the symptoms of hypopituitarism, which I would go through them, but I think you can figure them out, and I'm going to test you on it on the next slide. All right, infiltration, so you could have sarcoidosis. We talked about this, hemochromatosis. So you can have things that block up or prevent flow. So not necessarily complete infarction, but things that move into the walls of the blood vessel and actually cause problems to the blood vessel walls. You could have damage to the brain where there's swelling that could pinch off that little structure. Remember, it sits right inside the base of the skull in a little tiny area the size of a pea. Anything that causes swelling in there is going to smash the pituitary. Immunology, you could have your immune system attacking those structures. Iatrogenic, so do you remember the words iatrogenic and idiopathic? What were the difference? Iatrogenic was that who did it? The doctor did it. So it could have been because of surgery, some kind of surgery in that area. It could have been radiation therapy that caused swelling or inflammation. It could have been them trying to cure a cancer and it caused swelling there and caused damage to the pituitary. It could be infections. So that's an easy place for infections to get up and in to the base of the skull. TB, syphilis, we talked about viral infections that got up through the base of the skull. So any of those could happen. Idiopathic, we don't know the cause. There are some familial links with people with hypopituitarism. We just don't know exactly what the links are yet. And then it could be isolated. So it could be just one specific type of cell that's happening to it. It could just be a deficiency in GH alone, or LH, or FSH, etc. Or when we talk about something called pan-hypopituitarism, so you just look at this word up here and say pan, it means all of them are decreased. So in pan-hypopituitarism, all of them are decreased, which is your next homework question. So what symptoms would you expect from the 6 anterior pituitary hormones and hyposecretion? So this is asking you, in pan-hyposecretion, or hypopituitarism, what are the symptoms based on these 6 hormones? Okay, next let's talk about the neurohypophyseal disorders. And remember, the neurohypophyseal is talking about the posterior pituitary, which is connected to the hypothalamus by axonal connections, not blood supply. So the 2 hormones are, remember what? Vasopressin and oxytocin. I know instinctively you probably want to say ADH, but vasopressin is ADH, and if you want to jot that down, that'd be a great thing to do. So vasopressin or ADH. And you see a lot of the causes of this are actually causes that are related around the brain itself, like infections, brain damage, meningitis, taking drugs that get into the brain. You can see most of these are actually drugs that affect the brain, SSRIs, morphine, etc. Or, this is kind of interesting, so malignancies from small cell lung cancer. Lung cancer, there's something about it, it has a tendency to trigger changes in vasopressin. So a lot of these are affecting the brain. Vasopressin, you have to remember, is also known as ADH or antidiuretic hormone. What it does is it's released from the posterior pituitary in times when you need to retain what? Antidiuretic hormone. Retain water. Not sodium. Sodium is regulated by aldosterone. Water. So we need to retain water. Let's say you have low blood pressure. Maybe you have hypersolute. You're in a hypertonic state, so you have too many salts in your body. You need to retain more water, so ADH comes out. In that situation, when ADH is being abnormally released, way too much water released, you have something called syndrome of inefficient ADH, or SI-ADH. I know it's not the most creative name, but I didn't name it. But it's just telling you that you're releasing too much ADH, which means you retain too much water. Well, if you retain too much water, what do you accumulate? Where are you accumulating that at? Blood vessels. What's going to happen to your blood volume? Goes up. What happens to your blood pressure? Goes up, right? So it goes up, raising your blood volume, blood pressure. It can cause edema. So you're retaining lots of water. The problem with that is that this specifically retains water, not salt. So now you're diluting your blood, which means you're going to get states like hyponatremia or hypokalemia. So you get this hyponatremia, which means you have too little salt, which causes issues with neuromuscular junctions or neurons or muscles or cardiac tissue. But anywhere that needs that sodium for like depolarization, you can count on it's going to have a problem. That's SI-ADH. Diabetes insipidus is just the opposite. And the way you remember the symptom of this is diabetes insipidus' name looks like another diabetes called diabetes mellitus, right? The main symptom that we always think about with diabetes mellitus is that you start peeing out sugar, polyuria with lots of sugar in it, right? Diabetes insipidus does the same thing. Lots and lots of urine production. So what's happening with ADH in this situation? You're not releasing ADH. If you don't release an antidiuretic, what state do you fall into? You fall into a diuretic state, which means you urinate a lot, you urinate frequently. You're losing lots and lots of fluids. This causes dehydration. This can actually cause you to retain too much salt, right, compared to water, which can cause more of a hypernatremia state. But diabetes insipidus, when you go out drinking on Friday nights and you have a couple too many beers, it starts shutting down the hypothalamus. You don't release ADH, which means you start peeing a lot, and they call that breaking the seal. If you did the measurement, you're actually urinating out more fluids than you're bringing in, so it's not just because you're drinking a lot, it's because what you're drinking is the alcohol that destabilizes the membrane of the hypothalamus, which causes you not to be able to release ADH appropriately. So it's kind of an interesting pathway that's going on there. Right. The other hormone from the posterior pituitary is oxytocin. We call it the cuddle chemical because it makes you want to cuddle. It's primarily released at a couple times in life. It's released after an orgasm in a woman. It's released during childbirth in a woman, and it's released during breastfeeding in a woman too. So those are three primary times it's released. It helps her bond with her mate, helps her bond with her child, and helps her to feed the offspring. But oxytocin is also made in a man. Well, think about this. This is like prolactin we talked about before. If a woman releases too much prolactin, or a lot of prolactin, what it does is it comes back around the feedback loop and it shuts off the hypothalamus. So I left this blank intentionally because I want you to think about this pathway. Right? So you have this original endocrine gland. Oops, now that I see it, I actually kind of made a mistake by putting this in here because oxytocin, remember, has a neural connection and it also has a hormone connection. So the first thing you have is the hypothalamus, and the hypothalamus is connected neurally to the posterior pituitary. And then oxytocin is released, it goes down to the uterus, and the uterus does what? It contracts, right? It contracts. It causes smooth muscle contractions. Well, that contraction will send a neural signal all the way back up to the hypothalamus that says, ouch, ouch, release more oxytocin. So it sends a neural signal to the posterior pituitary, which releases more oxytocin. Uterus contracts more. It says, ouch, ouch, release more. What kind of loop is that now? That's a long loop, positive feedback loop. That's a loop you're stuck in that's a very positive feedback loop. Well, this is interesting because When the oxytocin is released, the oxytocin comes back up and says, don't release FSH and LH. If you release FSH and LH, I'm giving birth to a child right now, or I'm breastfeeding a child. You release FSH and LH, we can get pregnant again. So don't do that. Well, oxytocin in a man, if a man has too much oxytocin, it'll shut off his FSH and LH. FSH helps him produce sperm, LH helps him produce testosterone. So it reduces his sperm count, it reduces his testosterone count, it can cause gonadal dysfunctions. It can cause things like erectile dysfunctions. It can cause arousal, drop in libido. All those things can happen. So you really have to think about these feminine-like hormones, what they could be doing to a man. Right? It's the same with estrogens. We take a lot of estrogens in, like phytoestrogens in our food. Can those have an effect on men? Yeah, it can bring out our feminine characteristics. It can actually give us gynecomastia. It could give us, it can start competing with the effects of testosterone, decrease our muscle mass. It can make us raise our voice just a little bit, not lower and deeper voice, but having a lighter voice. It can do all those things. It may actually help our hair on our head be thicker and more lustrous, but there are a lot of downsides to that. I think I'd rather kind of go a little bit more bald than lose my testosterone. Right, so that's oxytocin. Those are the posterior, oxytocin and vasopressin. Right? Thyroid gland. So the thyroid gland releases a couple hormones. It releases the thyroid hormones, T3 and T4, but it also releases that chemical calcitonin that everybody seems to forget about. Right? So the thyroid gland, when you're releasing T3 and T4, it affects the metabolic rate. I've already mentioned this a little bit, but I'll come back again. And that metabolic rate, in addition to that, it helps regulate growth hormone epinephrine's ability to work. So when you look at the symptoms, you see symptoms that affect blood pressure, right, with epinephrine. Low T3 and T4 will actually prevent epinephrine from causing vasoconstriction, so you get a drop in blood pressure. Low growth hormone would decrease your bone density, would decrease your muscle mass. So they're important hormones. And over here to the side, I found this review slide that was kind of interesting. But with hypothyroidism, you'd see all these things decrease. Slow responses, things that are turning down, colder temperature, forgetfulness, infertility. All of these things are turning down. Blood pressure starts dropping, slow heartbeat. Well, if all those things are a result of hypo, what would hyper do? Just the opposite. So cause you to lose your hair a little bit more, cause your eyes to push out, which I'm going to talk about, cause increased heart rate, increased blood pressure, anxiety, which makes it harder for you to sleep, etc., etc., etc. And I have a slide devoted to this too. But you can actually check your thyroid, and I put this little examination thing in here. It's kind of cool. So you stand in front of a mirror, stretch your neck back, swallow some water, and as you're swallowing, look for engorgement in the neck around the Adam's apple or above the collarbone. Right? You can feel the area to confirm. Is it actually enlarged? Does it feel like there's a bump there? Right? And if there's a problem that's there, then maybe you want to get it checked out. Right? Calcitonin's main purpose is to lower blood calcium. So you have high blood calcium, and it wants to stick it onto your bones. It pulls it out of your blood and sticks it on your bones. So calcitonin is really good for building bones. Right? Calcitonin is not a life-important hormone. It's important to keep your bones strong, but if you lack calcitonin or something happens to these cells, you don't die because of lack of calcitonin. Right? It regulates your calcium, but there's another hormone that's actually way more important than calcitonin. Right? So let's talk about hyperthyroidism first. And the first type is called Graves' disease, and this is the bulk of the cases. So Graves' disease, what you want to know is it's an autoimmune problem. And what happens is the immune system makes antibodies that look exactly like thyroid-stimulating hormone. So thyroid-stimulating hormone normally comes over here to the thyroid and tells it make T3 and T4. Well, now these antibodies come over here and they fit in the receptor and they say, make T3 and T4. So now that person's body's making tons of T3 and T4. What kind of symptoms would you expect? Well, increased metabolism, so higher temperature, higher calorie burning, probably thin, probably hungry a lot, anxious a lot. Their epinephrine's going crazy, so their blood pressure's up a lot. Those are all symptoms you'd expect. Right? Women are more likely to have the Graves' disease, and there's actually, they believe, a hereditary component to it so far. Some of the other causes, benign nodules on the thyroid, so maybe you have a thyroid tumor that's actually a thyroid cell that's overproducing. Thyroiditis can do it, can overstimulate or irritate the thyroid, makes it overactive. And another common problem is that people that take too much thyroid hormone, you think, well, duh, but a lot of people don't think about it, right? So maybe they had a thyroid surgery and they had part of the thyroid removed and they're taking these pills, and maybe there was something that was like stunned about the thyroid for a short time where it didn't want to work, but now it's healed and it's starting to produce its own. Plus, they're taking this own medication. So Now they have symptoms of hyperthyroid because they're taking too much. Oh, I almost flipped to the next one without talking about this. So goiter. Goiter can happen in hypo or hyper. In this situation, there's a picture of the goiter, and you can see how it swells up. So a goiter, if something like Graves' disease, if this factory is producing but it's still being told make more, this factory will expand to accommodate. So they actually get a bulge coming out of the side of their neck because this thyroid gland is making so much thyroid hormone that it had to grow bigger to keep up with the demand. And another problem is called exophthalmos, and there's a picture of it on the next page, but this is when their eyes can actually start bulging forward, and I'll show you that. So here are some of the symptoms of hyperthyroidism. Okay, this is actually a goiter that's been removed right here, so you can see how large these are. This is exophthalmos. Like I said, the eyes, they're not just looking surprised, it's that their eyes are actually being pushed out. There are glycoproteins that are sticking along the muscles in their eyes and in the fat behind their eyes and pushing them forward, making them bulge out. So it's pulling on the optic nerve. So what's one symptom they could experience? Decreased vision, right? So vision loss, because their eyes are being pushed and their optic nerves being stretched. But you can see some of these problems, like if they're increasing metabolism, they're going to turn up their heat. They're going to have more demand for oxygen. So usually they're deeper breathers. They breathe heavier. Their heart rate's a little bit higher. They're sweating all the time. Their temperature's up. Their hair's softer and thinner. It's actually growing faster because of the thyroid hormone, but the problem is that it can't grow outward and thicken up, so it gets really thin as it grows outward. So sometimes it has a problem with breaking off or falling out because of that. And it's interesting because it's actually growing at a fast rate. I already talked about temperature. The clubbing. Clubbing is because of lack of oxygen. So lack of oxygen in the peripheral tissues during hyperthyroidism and because of that vasoconstriction causes this irregular shaping of the nails, and it's called clubbing. And you can see, and we talked about this back when we talked about epithelium. It can actually affect their menstrual cycles. It can turn down the regular menstrual cycles. It's almost like they're stressed all the time, which can actually turn down your menstrual cycles or affect your menstrual cycles too. And then emotional issues. They're very anxious, very agitated, very eager, nervous. You take them to a scary movie and they see one scary thing and they're sweating like crazy. Their heart's about to pound out their chest. They're all like anxious about it. Maybe it causes sleep disturbances and things like that. Just think if these people are extremely, like in their mind, body, hyperactive. What are all the symptoms that would come with that? That's hyper. Okay, hypothyroidism, just the opposite. So the most common cause, or one of the most common causes here, is Hashimoto's thyroiditis. This is also autoimmune. It makes antibodies that attack and destroy the thyroid. So when we talk about Graves, Graves turns up thyroid activity. Hashimoto's actually destroys it. Hashimoto's causes hypo. Graves causes hyper. So one of the problems could be treatment for hyperthyroidism. They had a treatment, they took too much of the thyroid out, and now they have hypo. It could be congenital problems where it wasn't developed completely when they were born. Radiation to the neck could happen. Neck's a highly exposed area, so if you take a lot of direct radiation, it can damage the thyroid gland. And then some of the side effects of hypothyroidism is hypothyroidism. What's it going to do to your metabolism? It's going to slow it down, right? So what's going to happen to your weight? You're going to get bigger. Here's before and after. So this is with hypothyroidism. This is without. You can see his face, his neck's a little bit more full. He's just a little bit heavier. You can almost tell by his outfit there. He's a little bit thicker in places. Their body temperature slows down, gets a little colder. They gain weight a lot easier. You can predict these symptoms, right? Myxedema is another symptom. Myxedema is talking about this puffiness. Puffiness in the eyes, puffiness around the face, puffiness around the joints. That's myxedema. Right? And don't forget, when we talk about primary and secondary, primary means there's something wrong with that person's thyroid. Secondary means maybe something in the pathway is wrong. Maybe they have the pituitary gland is being compressed and they can't release enough hormones, TSH, to stimulate the thyroid. So number 2, congenital hypothyroidism is called cretinism. Your job is to look up what the symptoms are. So look them up. Actually see if you can predict the symptoms as a child. If you have decreased thyroid, decreased epinephrine activity, decreased growth hormone activity. See if you can predict the symptoms. Look it up and then submit it. Next gland is the parathyroid, and I've already talked about this just briefly. The parathyroid hormone works against calcitonin. Calcitonin makes you lower your blood calcium because it's pulling calcium out, sticking to the bone. Parathyroid hormone works exactly the opposite. Parathyroid hormone comes out when you have low blood calcium, so its goal is to raise your blood calcium levels. Well, if you have disorders with parathyroid hormone, you can't absorb calcium efficiently from the GI tract. You can't excrete it efficiently or reabsorb it efficiently. I shouldn't say excrete. You can't reabsorb it efficiently from the kidney. You can't pull it off the bones effectively, so your blood calcium starts dropping. Do you need calcium to stay alive? Yeah, your heart needs it. Your heart depends on it. Your muscles depend on it. Your neurons depend on it. You have to have calcium, right? So here are some of the changes that would happen. With PTH, if you have too much of it, what would happen to your bones? Well, parathyroid hormone, watch what it does. Parathyroid hormone is released. If it's too much, it goes to the bone. It breaks the bone down to release calcium. What disease might you get? Osteoporosis. Parathyroid goes to the kidney and tells the kidney start reabsorbing as much potassium as you can. So then you start excreting calcium as you can. Well, then you start excreting phosphate, which will increase your risk for kidney stones, right? PTH, once it's gone to the kidney, it also activates vitamin D. Vitamin D goes to the small intestine and causes you to absorb calcium, bringing back the calcium in your body. So if you have too much of this, you're way cranking up your calcium levels, which causes heart arrhythmias. It causes neuroexcitability. It causes muscle tightness and cramping. So lots of problems with too much. Hypo-PTH means your calcium levels drop, which means you have to worry about neurons not firing, muscles not working right, especially respiratory muscles or cardiac muscles. So you have to worry about heart disorders or respiratory problems, right? So once you get that calcium out there, your calcium is extremely tightly regulated, and parathyroid is really the primary hormone that does that. If you don't have parathyroid hormone, you're going to die. If you don't have calcitonin, you'll still be fine, right? Because calcitonin is there to help lower your blood calcium. If you don't turn on PTH, you can naturally just not absorb calcium, and that'll regulate your calcium levels. Or you can naturally pee out calcium. That'll regulate calcium levels. You don't need calcitonin. You do need parathyroid hormone. Okay, so homework 3. What would be the symptoms of hyperparathyroid? Nuts, I forgot to put this in here. What would be the symptoms of hypoparathyroidism? Do me a favor, though. Look at an outside source and pull them out. So I gave you a lot of those clues, but go ahead and write down specifically what happens to the muscle, what happens to the neurons, what happens to the kidney, what happens to the bones. So write down those different effects. All right, adrenal glands. So the adrenal glands, another exclusive gland that just releases hormones. That's its whole goal. There are two sections, the medulla, or the medulla, and the cortex. Cortex is out here on the outside. Remember, cortex, bark of tree, means outer surface. The medulla is down here in the center. The medulla releases chemicals called catecholamines. So over here, you want to think epinephrine, norepinephrine, right? So pheochromocytoma is a tumor. I said that like that on purpose. It's a tumor in the medullary cavity. Well, so if you have a tumor that's overproducing epinephrine and norepinephrine, what kind of symptoms might they have? High blood pressure, blood vessels constricting a lot. They may get, ruptures, increased risk for stroke, heart disease. Their heart's going to fail because of all that pressure. Okay, so epinephrine, they're basically on an adrenaline high all the time. So what do? They remove that adrenal gland, or they remove the tumor. Do they stop ever making epinephrine then? Nope, they still make epinephrine. Why? Because if you have a tumor over in this adrenal gland and you remove this one, you always have a good healthy one on the other side. So pheochromocytoma is not usually a life-threatening situation, but it does cause health issues. And then the adrenal cortex. So on the outside, you have to remember the different layers. On the outermost layer, you make this aldosterone. In the layer just below it, you make cortisol. In the layer just below that, you make DHEA. It's an androgen. It's a masculinizing sex hormone. So 3 major hormones. Hypoaldosteronism, we actually talked about a little bit before when we talked about electrolytes, and we talked about it again when we talked about the kidney, if I remember right. But hypoaldosteronism, what does aldosterone do? Aldosterone makes you retain sodium. So with hypoaldosteronism, what's going to happen to your sodium levels? Well, your sodium's going to drop. Remember, when you're retaining sodium, you pull sodium in, what do you kick out? You kick out potassium. If you have hypoaldosteronism, it will make your potassium levels in your blood go higher, which causes lots of heart issues and could potentially kill you, right? It could make your heart seize up and you could die. So one of the big risks of hypoaldosteronism is that hyperkalemia. Right? The sodium is a little bit easier for your body to regulate because you can just urinate it out. And then hyperaldosteronism, now you have hypokalemia, so you're just losing too much potassium, but what are you retaining? Now you're retaining too much salt, which means you're going to want to retain water, which is going to make your blood volume go up, which is causing hypertension. Exactly. So some of these things, when you look at the name, they kind of tell you, or because of your past history, knowing these things, they tell you what to predict, what you can expect. Right? Another layer here, pseudohermaphroditism. So this is the DHEA layer, the innermost layer making DHEA. DHEA is a masculinizing hormone. If you see this DHEA in a little boy, what's going to happen? He's going to have more adult characteristics, and it looks like he's growing up faster. What if you see it in an adult male? Probably not much of anything, because he already has testosterone that's more powerful than DHEA. What if you see this in an adult female? If she has this masculine hormone in her, well, one thing's going to happen is her sex drive's going to go up, right? Because it's testosterone that gives us our primary sex drive. It's the androgen that does that. But the problem is it's going to turn on her masculine characteristics. So think of the effects of that. An adult woman that has too much DHEA. If she had a tumor here or something that's making too much DHEA, she may be growing facial hair, deeper voice, bigger muscles, right? My name used to be Bertha, now it's Butch, something like that. You know, it's a masculinizing characteristic. How about a small female child? If she has more masculinizing hormone in her body, what's going to happen to her sex characteristics? Well, let's look. So here's what happens. You can see that the structures, as far as whether it's a male or female, here's female structures like the clitoris, here's the penis and the glans penis. They're very similar. When you look at the labia, they're very similar to the scrotal sacs. So they all depend on testosterone or masculinizing hormones to differentiate what these are. Well, estrogen versus testosterone. So if a little girl is exposed to too much of a testosterone-like substance like DHEA, she'll actually start looking more masculine. So these are actually pictures of a baby girl, and you can see that they kind of look like small penis, and this looks like a scrotal sac with undescended testis. So that's an example of pseudohermaphroditism. In the situation, she has a vagina, she has ovaries, she has a uterus, she does not have testes, she does not have a real scrotum, but because the clitoris has been overstimulated with masculinizing hormones, it starts looking more like a glans penis, penis. And you see more characteristics like thicker muscle, denser legs, less breast tissue, hairier structures. You might actually see male pattern baldness happening with her, more facial hair. And an example of this would be, like I said, a tumor actually growing on that part of the adrenal cortex that's releasing too much DHEA. And this tumors it's hard to isolate them just to that layer with the DHEA. A lot of times what you'll see is they'll start producing more cortisol or even more aldosterone because it's just affecting all of those cortical regions. And we'll talk about that disease in just a little bit. So what would the symptoms of hypersecretion of DHEA be in a female child, a male child, an adult woman, and an adult male? And I kind of hinted towards that, but get your outside sources. Go online, find good quality sources, and then report your findings. Next is Addison's disease. So Addison's disease also affects the adrenal cortex. In this situation, you're not releasing enough of the adrenal cortical hormones. So the things you have to worry about is not releasing aldosterone, not releasing cortisol. Those are important for life. DHEA is not a big deal. If they don't release enough DHEA, maybe their sex drive goes down, but it's not life-threatening. Well, I guess if you're a man, you may think that having decreased sex drive is life-threatening, but technically it's not going to kill you, right? But if you have low aldosterone, what could happen to you? Well, aldosterone makes you retain salt. You can't retain salt, so you start urinating lots of salt out, which means that you're going to have hyponatremia, and it's going to start irritating your muscles, your neurons. It's going to decrease neuromuscular function, and it could potentially kill you. What's it going to do to your blood pressure, releasing all that salt or losing all that salt? It's going to make your blood pressure drop. So when you have large spurts of this, when they suddenly stop making aldosterone or make aldosterone and cortisol at such low levels that it's life-threatening, they call that an Addisonian crisis. Their blood pressure drops, their blood sugars drop. Cortisol causes you to release blood sugar. If you don't have cortisol, your blood sugars plummet. They go down really quick. So in an Addisonian crisis, these chemicals aren't coming out, so they lose salt, they lose sugar, they urinate it out. They basically look like they have diabetes, and they don't make aldosterone, so they don't retain salt very well either. Right? Another unique feature or characteristic is this pigmentation. So there's a chemical, and it's the pathway that does it. The chemical ACTH, when it's made, you also make a chemical that's a melanocortin. So it goes to the melanocytes and tells the melanocytes start getting busy and making lots of pigments. Well, think about this. If your adrenal gland doesn't work and you don't make cortisol, what's your hypothalamus going to think of that? Your hypothalamus is going to think, wow, turn up the ACTH. Well, if it makes lots of ACTH to try and fix the low cortisol aldosterone problem, it's going to make lots of that melanocortin. And that melanocortin is going to go to your skin and cause these pigmented areas. It actually causes kind of a golden hue. So they call it bronzing. We talked about it a little bit before. Here you can see a normal hand. Here you can see a hand that's been bronzed because they release too much of this melanocortin. Right? So homework number 5. We talked about Addison's disease. What happens when you have a decrease in aldosterone and cortisol? Now look at Conn's syndrome. You're going to look it up. Conn's is exactly the opposite. It's hypersecretion of those hormones. So what's going to happen when you hypersecrete aldosterone? What symptoms would you expect? What detrimental or chronic effects is this going to cause? And I'm hoping in your head you're already putting together what are going to be the bad things of making too much aldosterone. Okay, next one, Cushing's disease. This primarily revolves around cortisol. So Cushing's disease, you're not making enough cortisol because the pituitary is not saying to do it. So pituitary gland isn't secreting enough, right?